Yeah, good afternoon, all of you. We are back with another topic, that is ultrasound examination of kidneys. We'll be talking majorly. We'll be talking about the normal appearance of the kidneys on ultrasound examination, and there will be some pathological images as well. We'll be discussing pathologies in brief. So I'll be covering this topic under these subheadings. We'll be first discuss the accurate techniques to do the ultrasound examination of kidney, then normal ultrasound examination appearance of the kidneys. Then we'll be talking in brief about the pathologies. So as we know that the renal parenchyma, once we take a cross section or cut section of the kidney, we can differentiate the renal parenchyma into the cortex, the outer cortex, and the inner medulla. The medullary pyramids are directed towards the renal pelvis, and the renal pelvis is filled with renal sinus fat. As we can see, some yellowish structure in the renal renal sinus region or renal pelvis region. That is actually the renal sinus fat. And if you talk about the microscopic appearance of the kidney, we know that the nephrons are the functional unit of the kidney, and the Bowman's capsule or Malpighian corpuscles are predominantly, they are situated within the renal cortex. So renal cortex is filled with the Bowman's capsule, the proximal convoluted tubule, and distal convoluted tubule. The roof of Henle is predominantly located within the renal medullary pyramid. The pyramids are formed by the roof of Henle and majority of the part of the collecting ducts. So all the nephrons, the Henle's loop and the collecting duct, majority of it is located within the medullary pyramids. And the cortex is formed by the Malpighian capsule or the Bowman's capsule and the proximal and distal convoluted tubules. So the collecting tubules later on, they open into the minor calyces and then the major calyces of the collecting system. And later on, the renal pelvis is formed and the ureter. So majority of these structures will be seen on ultrasound examination: the renal cortex, the medullary pyramid, sinus fat, etc. all. That is how a cross-section anatomy of the kidney looks like. So let's try to see all the structure, or majority of the structure, on ultrasound examination. For examination of the kidneys, we normally use the transducer. Which transducer? The convex probe. The curvilinear probe is used because we need to reach a deeper depth, and we need to examine the kidneys through the liver or maybe through the spleen. So it's a deeper structure, it's a retroperitoneal structure, so we need a convex probe. Of course, in case of a thin patient and in pediatric population, you can use a linear probe, but though the resolution will be high, the depth of penetration will be less. The usual indication for doing ultrasound examination of kidneys are flank pain, urinary complaints like dysuria, hematuria, anuria, oliguria, and urinary incontinence, voiding problems, and of course for evaluation of the renal parenchymal disease. For examination of the kidneys, the preparation required is the full bladder is always there. For kidneys and urinary bladder, we need to do the examination of KUB together. So always it's a mandatory requirement that the bladder is full. And the approach usually used is the patient is lying in a supine position, and we examine the kidneys, either kidneys, in a different fashion. For right kidney, the approach is anterior, lateral, and posterior. The acoustic window which is used for examination of the right kidney is liver. So liver parenchyma is an important solid organ that will help us to visualize the kidney, as the kidneys are retroperitoneal structures. So we can avoid bowel loops and the bowel gas shadow by using the liver. Similarly, for left kidney, we have a lateral approach or a posterior approach. We don't have an anterior approach because majority of the kidney from left kidney from anterior aspects will be obscured by the bowel gas shadow or gas shadow within the stomach. So this is how the position. This is how the position of a patient should be while doing right kidney examination of the right kidney with the ultrasound probe. As we can see, in a longitudinal fashion or a craniocaudal fashion, we can put the probe in a CC direction as shown in the figure, or as in the show over here, as depicted over here. And on ultrasound examination, the appearance of the kidney is shown in the other figure. We can differentiate the renal capsule, the renal sinus fat, which is appearing as a bright echogenic structure, then the renal cortex, somewhat intermediately hypoechoic, while the renal medulla are more hypoechoic. Though we cannot see the calyceal system and the renal pelvis unless it is dilated. In case of a normal kidney, the renal medullary sinus fat will obscure the visualization of the minor calyces, but once they are dilated, they can be easily visualized. Of course, both the kidneys should be examined in the longitudinal as well as transverse fashion from end to end. So if you are examining the right kidney in a transverse fashion or left kidney in transverse fashion, you have to use the probe. We have to move the probe in a fan-like direction so that most of the renal parenchyma can be scanned. Similarly, when you are examining the kidney in a transverse fashion, whether it is right or left kidney, you have to go from craniocaudally and examine all the sections of the entire renal parenchyma. Again, on the transverse section, we can see the renal cortex, which is intermediately hypoechoic, which is slightly echogenic as compared to the renal medullary pyramids. Similarly, left kidney is visualized through the acoustic window of the spleen. The renal parenchyma of the spleen will help us to visualize the kidney. There will not be any obscuration because of bile gas shadows as the renal parenchyma is there. This is how it is examined in the longitudinal fashion, and similarly left kidney in the transverse fashion. So these are the techniques for examination of the kidney. For right kidney, we use liver as acoustic window. For left kidney, we use spleen as the acoustic window. For right kidney, the examination can be done from anterior, lateral and the posterior aspect, while for the left kidney, the examination can be done from lateral and the posterior aspects. So normal appearance of the kidney on ultrasound is, it is usually in the craniocaudally, it measures 9 to 12 centimeter, and it is 4 to 5 centimeter in width and 3 to 4 centimeter in thickness or anteroposterior dimension. Of course, the Gerota's fascia cannot be visualized distinctly, but a brightly echogenic structure outside the renal cortex is the Gerota's fascia and renal capsule, which is combinedly seen as a brightly echogenic structure. The renal sinus, we will see this in the ultrasound image as well, or we can just go to the next image. So we can correlate the gross anatomy of the kidney with the ultrasound examination appearance of the kidney. So you can see the bright echogenic outer capsule, which is actually the interface between the Gerota's fascia and the renal capsule. Then somewhat intermediately hypoechoic, which is slightly echogenic as compared to the renal medullary pyramid, is the renal cortex. And the renal pyramids can be seen as pyramidal structure, multiple pyramidal structure, which is actually the renal medulla, and we can see they are slightly hypoechoic as compared to the renal cortex. So this corticomedullary differentiation is very important for diagnosis of the renal parenchyma disease. The central echogenic branching area actually is the renal sinus fat, as the fat appears echogenic on ultrasound examination, and somewhat slightly branching hypoechoic anechoic structure within the hilum are the calyceal system and the pelvis. The ureter cannot be easily visualized. Proximal part of the ureter can be visualized most of the times up to the PUJ, but majority of the ureter is a bit difficult to visualize unless it is dilated. Okay, so when the ureter is dilated, it is easily visualized. So let's talk about some basic pathologies. We'll not be talking much about in details about this pathology. If you go into the pathologies, we should know what is the common term known as hydronephrosis. So actually it is a urinary stasis because of any obstruction to the flow of urine. The obstruction can be within the ureter, or it can be beyond the ureter, or at times it is because of the reflux. The obstruction is because of incompetent vesico-ureteric. The stasis is because of the incompetent vesico-ureteric junction. So hydronephrosis is basically urinary stasis within the pelvic calyceal system. We can grade the urinary hydronephrosis or renal hydronephrosis into 4 categories on ultrasound examination. It is mild, moderate and severe. There is other grading called grade 1 to grade 4, but it's usually commonly used for IBP. It's not easily seen on ultrasound examination. For ultrasound examination, we commonly categorize it into mild hydronephrosis, moderate hydronephrosis, and severe hydronephrosis. In grade 1 hydronephrosis, there is only dilatation of the pelvic renal pelvis. The major and minor calyces are not dilated. In grade 2 hydronephrosis, there is dilatation of the major calyces as well. In grade 3, there is dilatation of the minor calyces as well. And in grade 4, there is ballooning of the calyces. Then when the minor calyces are grossly dilated, they are appear as a balloons or much dilated, and there will be renal parenchymal thinning associated renal parenchymal thinning as well. So on ultrasound examination, the moderate hydronephrosis is between grade 2 to grade 3. So at times it is very difficult to differentiate between dilatation of minor and major calyces. So we treat it as a moderate hydronephrosis. So when there is only dilatation of renal pelvis, we call it as a mild hydronephrosis on ultrasound examination. And when there is dilatation of the calyceal system, we call it as moderate. And when there is ballooning of the calyceal system with renal parenchymal thinning, we call it as a severe hydronephrosis on ultrasound examination. So let's have some pictorial appearance. We can see the ultrasound examination images. We can see in the first image, there is only dilatation of the renal pelvis. Neither the renal calyces, minor or major, are dilated. So this is what is called as pelvic ectasis or pylectasis, and this is what is called as grade 1 hydronephrosis. In the second image, we can see there is dilatation of renal pelvis and there is dilatation of the major calyces, and this is this is how the grade 2 hydronephrosis looks like on ultrasound examination. As in grade 3, there should be dilatation of the minor calyces as well. There is dilatation of minor calyces apart from the major calyces. And of course, in grade 4, there is ballooning of the calyceal system or minor calyces, and there is renal parenchymal or cortical thinning. So this is in brief about the hydronephrosis and how the ultrasound examination appearance of the hydronephrosis is as per the grading. Let's talk about in brief in some pathologies like congenital pathologies. Common congenital pelvic junction obstruction is a very common congenital pathology which we see during antenatal ultrasound as well as in the pediatric ultrasound examination. The reason behind it is there is obstruction to the flow of the urine at the pelvic junction due to some irregular thickening of the pelvic junction wall or some wall-like mechanism. So the obstruction results in development of hydronephrosis. So even in the antenatal ultrasound examination images provided below, we can see both the kidneys of the fetus are dilated. We can see the renal parenchymal thinning. Even in 3C image, we can see severe dilatation of the pelvic calyceal system, and the renal parenchyma is severely thinned. Again, there is grading. We can grade the dilatation of the pelvic calyceal system. Another common pathology which we commonly see during ultrasound examination is a congenital anomaly, horseshoe kidney. We can see the kidney is the inferior pole region renal parenchyma of both the kidneys is fused by an ischemic renal parenchyma. So it is extending, the fused kidneys are extending anterior to the IVC and aorta. We can see its appearance as a horseshoe appearance. We can confirm it by CT, contrast enhanced CT examination. Ectopic kidney is very common pathology we commonly encounter during the routine ultrasound examination. So once you are not able to visualize the kidney in its normal anatomical position, always look for the kidney in its ectopic position. The ectopic position can be variable. It can be slightly lower lumbar region, it can be prevertebral region, it can be pelvic region. And when there is cross-fused ectopia, the ectopic kidney can be on the other side of the contralateral side of the body and will be fused with the other kidney. So if it is right-sided ectopia, the left kidney will be on the right side and will be fused with the right side. So ectopic kidney should always be looked for, when you are not visualizing normal kidney, you always look for its ectopic position. Let's talk about in brief about urolithiasis. It's a very common abnormality for which the ultrasound examination of KUB is advised. The important signs that will help us diagnosis of renal stone or urolithiasis are: you will see a brightly echogenic focus within the pelvic callus system. It can be within the minor calluses, it can be in the major calluses, it can be within the renal parenchyma, it can be within the ureters. So, brightly echogenic focus, and this is what is called as distal acoustic shadow. Very important sign for diagnosis of renal stones. This is because of all the ultrasound beams which are incident on the renal stone or the calculus are being reflected back. So there is no ultrasound beam passing beyond this. That's why there is shadow. So this is what is called as distal acoustic shadow, and very important sign for diagnosis of renal calculi. Similarly, there is one other important sign, what is known as twinkling artifact, which is very important for diagnosis of tiny calculi within the pelvic callus system. So if you put a color Doppler box, if you are seeing a brightly echogenic focus within the pelvic callus system, and it is very tiny and you are not sure about what it is, so you can just confirm it by applying a color Doppler box, increase the pulse repetition frequency to the max, and if it's still this artifact, the twinkling artifact is mixture of all the colors. We can see we seen distal to the echogenic focus, which is actually the calcification. So this is not diagnostic, but it is very helpful for diagnosis of tiny calculi. This can be seen also in the tiny renal calcifications, can be seen in case if there is air within the pelvic callus system. This varied appearance of the various calculi on ultrasound examination. A staghorn calculus is a big calculus extending from the renal pelvis into an entire pelvic callus system or part of it. An ultrasound examination, you will see an irregular echogenic focus with irregular multiple distal acoustic shadow areas, and the diagnosis can be confirmed by CT urography or on X-ray KUP. Diagnosis of ureteric calculus is maybe we can say you need to be a bit meticulous about for diagnosis of this, because many a times a tiny calculi will be difficult to visualize as the ureter is obscured by bile gas shadows and it's entirely retroperitoneal structure. Especially the mid to distal ureter portion, it's a bit difficult to visualize because of bile gas shadows. But once the ureter is dilated, you have to trace the ureter in a longitudinal and transverse fashion, and you have to localize the calculus. This is how a VUJ calculus looks like. Many a times a tiny VUJ calculi can be very tiny, maybe up to 2 to 3 mm. So you have to be very careful for diagnosis. To rule out the VUJ calculi, you have to put the probe in the suprapubic region in a transverse fashion and try to localize the VUJ and then try to trace the distal ureter. So let's talk about in brief diffuse renal diseases. The diffuse renal diseases are not, they involve the entire renal parenchyma. So it also known as renal parenchymal disease, that can cause a very contracted small kidneys or that can cause enlargement of kidneys. The small contracted kidneys are seen with chronic infections, other chronic diseases like hypertension, diabetes, or because of some medication, the renal parenchymal affection is there. So these are what is called as renal parenchymal disease. When what will we see will be the loss of normal corticomedullary differentiation. In early stages, there can be just increase in the renal cortical echo beyond the normal. So the renal parenchymal echo is somewhat equal to that of the spleen. Okay. So if it is more than that, we can say that it's grade 1 increased renal grade 1 or grade 2 increased renal parenchymal disease. But in later stage, we can see brightly echogenic renal parenchyma, and there will be loss of corticomedullary differentiation. And in advanced stage, the kidneys will be shrunken. They will be small in size. And what is known as acute renal disease, in which case of acute renal injury, because it may be because of some infections, or it may be because of uncontrolled diabetes, or maybe bilateral pyelonephritis. So the kidneys will be bulky and hypoechoic now. They will not be echogenic. They will be hypoechoic. Again, the renal parenchymal differentiation between the renal cortex and medulla will be reduced, but the kidneys will be very bulky. You can see the kidney of size 12 centimeter and above. In the AP dimension, of the kidneys in hypoechoic bulky kidneys will be more than 6 centimeters, 6 centimeter and above. So that's all about the diffuse renal disease. Let's talk in brief few slides about the focal renal diseases. So focal renal disease definitely commonest, the pathology, focal pathology which we see in kidneys during ultrasound examination is renal cortical cyst or parapelvic cyst. The cortical cysts are very common as compared to the parapelvic cyst. As we can see, well-defined thin-walled anechoic structure with echogenic thin walls, no solid component, no internal septae, no calcification. So this is simple renal cortical cyst. They can be some bit complicated. At times there can be septation, there can be wall calcifications. But if you are seeing some solid component, thick hypoechoic walls, then you should think about some other pathologies, neoplastic pathologies, tumor with necrotic changes instead of a simple renal cortical cyst. And that needs to be evaluated with other imaging. That's what all about cystic lesions. Now the solid lesions, few solid lesions that we can talk in such a small session. The commonest one is again a brightly echogenic lesion which we commonly see, which is cortical based, the renal angiomyolipoma. This is how a renal angiomyolipoma looks like. You can see a brightly echogenic, homogeneously echogenic rounded structure within the renal cortex. The margins are relatively well defined. You can see the normal and abnormal renal parenchyma. This one important is for solid lesions of the kidney. One important investigation of choice is contrast enhanced ultrasound examination of the kidney, though it is rarely done because we have other imaging modalities which are easily available, that is CT and MRI. But a contrast enhanced examination of the kidney can help us to differentiate between various kinds of solid lesions within the kidney, whether they are benign or malignant. The enhancement pattern will be different between a benign and a malignant lesion. As we can see, an angiomyolipoma on contrast administration, we can see it is enhancing during early phase as well as it is persistently enhancing during delayed phase. Early phase it is not enhancing much, but in delayed phases it is persistently enhancing. So it is retaining contrast, which is suggestive of a benign lesion. Another important benign renal mass is oncocytoma. A typical appearance is the hypoechoic, well-encapsulated mass. We can see the capsule of the lesion, but there is an important sign is central hypoechoic scar. We can see a branching hypoechoic scar at the center of the lesion, and this is typical of renal oncocytoma, but not always seen. It may be difficult to differentiate between oncocytoma and renal cell carcinoma many times. Again, contrast enhanced ultrasound examination. This is what is called a spoke wheel examination sign. The contrast enhanced ultrasound examination can also again help us to differentiate between a suspicious oncocytoma and renal cell carcinoma. We can see a hypoenhancing, non-enhancing central scar, and the enhancement of the lesion is persistent. It is enhancing in the early phase, in the delayed phase, and even the much delayed phase, it is retaining the contrast. So this is a sign of a benign lesion, which is actually an oncocytoma, and the central non-enhancing scar is helping us to diagnose this. Coming to the malignant lesions of the renal parenchyma, definitely renal cell carcinoma is the most common malignant lesion which we encounter during ultrasound examination. Again, the appearance is varied, but most of the times it's hypoechoic, though usually rounded or irregular structure, but hypoechoic as compared to the rest of the renal. It can be isoechoic or it can be even hypoechoic at times because of necrotic changes inside the nerves. Again, contrast enhanced ultrasound examination can help us to differentiate. As we can see, after administration of contrast, the lesion is enhancing in the early phase, and during delayed phase, the contrast is washing out. So this is a typical sign of malignant lesion. So that is how we can differentiate. On B mode ultrasound, we can see the lesion is somewhat echogenic, slightly echogenic as compared to the renal parenchyma. So it's a bit confusing mass. So once we administered the contrast, we can see the enhancement pattern is more in favor of a malignant lesion. So that is in brief, we talked about the ultrasound examination of the kidneys, their common pathologies, and normal appearance of the kidneys on ultrasound examination. So we can discuss all these topics we'll be discussing all these topics in very detail in our course. Thank you. Have a good day.